Oh, can we stop? Hi, my name is Dr. Stefan Kertész. I'm a professor of medicine at the University of Alabama at Birmingham, an internist and an addiction medicine doctor. I take care of patients who have long-term pain, patients in primary care who have complex psychiatric and social issues, and I'm going to be talking about care for patients with long-term pain. There's some disclosure here which is required. I have no financial affiliations, grants, or honoraria with commercial entities in this area. I should say that my wife owns stock in her own portfolio in Merck, Abbott, and Johnson & Johnson. It's separate from mine, and it's a small portion of her assets. I do intend to reference off-label use of buprenorphine in particular, or the buprenorphine naloxone combination product, which can sometimes be used outside of addiction care, but for pain care. This is not FDA approved, but was mentioned in a guidance from the United States Department of Health and Human Services this autumn. Another acknowledgement I want to make is that I'm offering my own views here and not those of either the University of Alabama at Birmingham or the United States federal government. I've taken a few slides from my colleagues and friends, and you'll see them when they come up. The objectives here are as follows. People who attend this should be able to summarize the policy context related to opioid prescribing in the United States. The second is to be able to describe a psychophysiologic model of pain, of chronic pain, and of its relevance for planning care. The third is, as a result of hearing this talk, you should be able to articulate the evidence on opioids in chronic pain, for and against. You should be able to differentiate forms of dependence that can emerge in people who receive opioids long term, and adhere to reasonable standards for prescribing practices. Finally, describe the evidence on favorable use of taper and common policy missteps. Let's talk about the policy context. The policy context, in a certain way, is straightforward. We had 70,000 drug overdose deaths in the United States in 2017. As I speak, the numbers for 2018 are about to come out. They're probably going to be almost as bad, maybe slightly lower. There were 45,000 of those drug overdose deaths that did involve opioids, not necessarily prescribed, but this tragedy creates very pressing questions. One of the obvious issues is raised by the history of opioid prescribing and opioid-related deaths and hospitalizations from 1999 to 2013, where you see two parallel lines here and data summarized by the CDC. These curves end in 2013, as we're going to get to in a moment. But that suggests that there is a relationship between how much we prescribed and how many opioid-related deaths happened. These curves are also from the CDC, and what you should see here is that the deaths related to opioids have changed over the last 5 years or so. Deaths related to commonly prescribed opioids such as hydrocodone and oxycodone and morphine are all shown from 2011 to 2016 in relatively flat curves. That remains the case all the way through 2017 as well. Deaths involving heroin began to rise in 2011. That's kind of a green line. And deaths involving fentanyl, specifically illicitly manufactured fentanyls, began to rise. And that's the blue line that is skyrocketing upwards as of 2016 and continued to do so in 17 and 18. One of the big challenges we have when talking about overdoses related to opioids is that each overdose death event itself involves multiple substances. This is made clear by this slide from the CDC. Here, I've named each one of several drugs that we can prescribe from fentanyl and heroin and hydrocodone and methadone, and shown a column representing the total number of deaths from involving that drug. The red bar within that column represents the number of deaths across the country in medical examiners' offices reported to the CDC. The red bar is the number of deaths where that was the only drug they reported. They may not have even looked for others. The orange part of that bar represents the number of deaths where other drugs were found, including alcohol, in the same person. In other words, whenever you hear the words opioid overdose, it is possible a person died just from an opioid, but most often it's a death that involves a polydrug poisoning, in which opioids are sort of maybe the final straw. The other policy context thing we have to recognize is the big drop in American opioid prescribing since 2011. This is from commercial pharmacy database system IQVIA. The lines going down, particularly that big green band going down, represents the drop in the number of high-dose prescriptions in the country. All of the lines are going down. The orange is sort of lower, medium dose. Blue is lower dose. You don't see much change in extremely low-dose prescriptions. But essentially, there's been a big drop in prescriptions for people who were receiving higher doses since before the CDC guideline. This has led to some interesting problems. This is an image from the Washington Post published in September of 2019. The article says, opioid crackdown forces pain patients to taper off drugs they say they need. And we'll talk about this more, but that's a dilemma. Obviously, there's a reduction in prescribing in response to the pressing tragedy. But how do we understand the tragedy that we often call the opioid epidemic or the opioid crisis? There's two ways of looking at it. And interestingly enough, those two ways were perfectly illustrated by two speakers at a White House U.S. government press conference in the summer of 2017. And the two speakers were the president's advisor, Kellyanne Conway, and then Secretary for Health and Human Services, Tom Price. The first framing was offered by Tom Price, the second by Kellyanne Conway. So Tom Price spoke up, and I've just chosen a quote, saying, what is the NIH doing? Hopefully pain medication that is not addictive or narcotic. Basically, the story in that framing is these drugs are addictive, we prescribe them, people get hooked, particularly your kids, your adolescents, your 25-year-olds. If we could just come up with the right med, this problem goes away. Surprisingly, the other person at the podium undercut him by offering a different story, even though they work together. Kellyanne Conway said, we recognize that this is a polydrug problem in our nation, that we are a nation that consumes legal and illegal drugs at an alarming rate. This involves public health, the medical community, healthcare delivery system, law enforcement, devastated families, and those in treatment and recovery. Put another way, even though I'm sure in many ways they agreed and were working together, Kellyanne Conway offered a view of the crisis that was a little bit different, involving multiple substances and communities in distress. How you conceptualize the problem obviously tends to guide the policy solution that you favor. Overdose dose and addiction is our problem. That's the top line issue. So you have to decide how much weight do we assign to our pain care traditions and our prescribing practices in driving this. That's a policy decision as much as a science one. The second is pain. How do you understand it? What is it? How do we take care of it? This often gets overshadowed when we discuss opioid prescriptions because we're not thinking about the underlying pain issues. To summarize policy, there's a relationship between our opioid prescribing history and our current crisis. Second, prescriptions are an attractive point of leverage for policy and for litigation. Third, there's other causal factors. And finally, the benefits and the downsides of our current course correction are things we're still going to have to determine. So what about pain? Because pain certainly played a role in all that prescribing of opioids. According to federal survey data, 23.4 million Americans suffer severe and debilitating chronic pain. About 10 million are on chronic opioids presently. Again, this is calculated off of a federal survey. Chronic pain can be a terrible experience, not for everybody, but for some. And the data in total, it shows that any single modality treatment for severe chronic pain only has predominantly short-term follow-up trials. That applies to opioids, to cognitive behavioral therapy. Almost all of those treatments might have maybe one trial that's over 6 months long, but not much more than that. Any single treatment tends to work well for a minority, usually. That applies for everything, medications and non-medications. Any single treatment tends to offer modest benefit if you calculate the mean benefit in the two arms of any randomized controlled trial. So now we have a real dilemma because it's a terrible problem and no single treatment is great for it. The model for pain is really important here because in some ways we've been taught incorrectly. Ineffective models for the problem you want to fix impede clear thinking. So let's discuss acute and chronic pain. And this is going to take you back to medical school in certain ways, but it's also going to change it up. Let's talk about a summary for the processing of acute pain. Many of you can probably see the image of the brain. There's some blue lines that are running up from peripheral nociceptive receptors, the place where the pin goes in, the knife cut, the bullet wound, the injured knee, whatever it is. It sends a signal up, the thalamus processes it, sends some sort of signal to the sensory motor cortex, and there's a moment where the person begins to say something is going wrong. All along, even with acute pain, there's always a role for the other systems in the brain to decide what that thing is. The brain is involved in executive control, assessing the level of threat, emotions and mood, motivation and learning, memories and beliefs, fear and survival. Some of you may have met somebody who was deeply in pain because they had stepped on a nail, only to discover that the nail had gone through the sole of their boot but never actually got into their foot. That's a moment where the brain saw a threat, turned on the pain response, and then actually it wasn't an injury to a nociceptive receptor. That's something that really happens because pain is not just a peripheral sensation. It's an event that sort of goes into your system and is interpreted and framed in terms of a response that you need to make. There's a little bit of noise outside because we have some news going on here today as we speak. Okay, let's talk next about acute pain in a little bit broader way. Central pain generators include factors that affect all of the brain pathways influencing this dynamic, such as grief, infections, panic, social stress. I personally remember a time when I was writing my very first grant proposal and was sitting doing some precepting of medical residents. I was in my 30s, felt something funny in my chest, and within an hour I asked my colleagues to do an EKG on me, even though it was extremely unlikely that a 36 or 37-year-old man would have a heart attack. The problem for me at that point was a stressor, which was writing my very first grant proposal. Of course, I didn't have a heart attack, but that's really a sign of how central processing can influence the perception of acute pain, in addition to the peripheral pain generators. And in this graphic, I've made those bold and bigger font so you understand that most of the time acute pain is predominantly driven by the signal coming in from outside the brain. Go to chronic. All the same systems are involved. There are peripheral pain generators still to varying degrees. I mean, somebody who has a recurrent inflammatory disease, a degenerative condition, they may very well be having repeated stimulation from peripheral pain generators and nociception. But at the same time, those central pain generators become a lot more important to the experience of chronic pain, on average. Social stressors, psychological factors, distressing illnesses, your ongoing medical problems, a history of addiction and recovery, psychiatric disorders, all those things also influence the experience. The pain response, again, is an individual who feels emotional distress because that's how the brain gets your attention. It tells you, I'm in trouble now, things are wrong, I need help, I need to recover. But now with chronic pain, it's going on for a long time, and those distress reactions aren't always very helpful for continuing with life. What does this mean for caring for patients? My approach, based on this model, when talking to somebody who says that they do have long-term pain, is to assess the following. What are the social stressors in their life? Where are you working? What's going on with your kids? Has somebody passed away? Psychological factors, the psychiatric history. Do they have depression, anxiety, post-traumatic stress disorder? What distressing illnesses does the individual have at the present time? If you are in the middle of a cancer workup and you have a pain problem, the pain problem is going to feel worse because you're worried you have cancer. What medications is the individual on? We'll come back to that because medications can influence the pain experience for good and for ill. Peripheral pain generators still matter. The disease process might be fixable. You still need to think about the injured spine, the injured shoulder, the neurologic degenerative disease, psoriatic arthritis, whatever it is. And what is the harm and the benefit of the current treatments that the individual is using, which may well include opioids at the time you meet them. I often spend some time looking back in time to ask what past care got us here. Very often with people with long-term pain, there's been a history of promises that were not met through high-priced or interventions of some kind that just didn't work. We build a narrative together of how we got to the present situation. And the plan in terms of recovering people from chronic pain, whether that pain is going to persist at some level or it's going to go away, is to emphasize goals of activity, to talk about the drivers of the pain experience, which the brain is essentially producing in response to peripheral and central stimuli, to address them if we can, which we can't always do in full, and to address any distress that impedes recovery-oriented activity. If a person is in massive agony and can't go to physical therapy but for an opioid prescription, it probably might be worth prescribing that opioid if you can manage the risks involved, because what you want to do is help the person proceed in a recovery-oriented direction. What's pain relief? Based on the model that I've just shared with you, pain relief is not just changing what is felt by those peripheral nociceptive receptors. Of course, splinting people, giving the anti-inflammatory drugs, and to some extent opioids, interrupt the signals from that peripheral injury. At the same time, I've just kind of offered a model where pain is an experience generated by the brain, and it involves affect and mood. In fact, if the brain did not make us feel alarmed, worried, and fearful in response to painful stimuli, we would not have survived as a species. I mean, if you could imagine this, imagine I was shot with a gun and I said, interesting new sensation today. I wonder what I should do about that. That really would not be adaptive. We are adapted to feel emotionally alarmed when there is pain. Unfortunately, that's not so helpful with long-term pain, but you can address those central drivers as well. Yoga, cognitive behavioral therapy, many of the treatments that are out there, each one with only a small average effect. But you know why opioids can also sometimes be helpful? Because they address the very same mechanisms. And of course, that's why in acting on those emotional and affect pathways, they can also be problematic. Let's talk about the evidence. I've listed here from the Veterans Affairs Health Services Research and Development branch a report of all the various therapies that do have some evidence for them, from acupuncture to Tai Chi. This doesn't mean that every single one of these treatments works for every single person. People are different, but these things all have some significant evidence for them. What about opioids? Well, the challenge that arises for us as clinicians is that conversation with the patient. And this is from the New York Times, and it's by a columnist who's a physician. And she writes, "Undertreating pain, we're admonished, violates the basic ethical principles of medicine. On the other hand, we are lambasted for overprescribing pain medicines, creating an epidemic of overdose deaths. For patients with chronic pain, especially those with syndromes that don't fit into neat clinical boxes, being judged by the doctor to see if they merit medication is humiliating and dispiriting. This type of judgment, with its moral overtones and suspicions, is at odds with the doctor-patient relationship." And then she writes, "As Mr. W and I sat there, sizing each other up, I could feel our reserves of trust beginning to ebb. I was debating whether his pain was real or if he was trying to snooker me. He was most likely wondering whether I would believe him." And that kind of captures the moment when you're thinking about those issues, sometimes in clinic, maybe not always, but it can happen. What do we know about the efficacy of opioids for chronic pain? Sometimes it's said that there is no efficacy or there's no evidence of efficacy. It's probably better to say that we have limited evidence, but we can talk about it, and it's meaningful in this conversation. Meta-analyses of various opioid trials with 3 to 6 month follow-up, typically comparing opioids to placebo, typically high quality, show that opioids are involved in average, statistically small but significant improvements in pain and in physical functioning. Opioids versus non-opioids, here the quality of the studies goes down. They're low to moderate qualities of 3 to 6 months follow-up. Similar benefits to both arms. So remember what I said at the beginning. Every single intervention seems to have a small to average benefit on average. One randomized controlled trial, which we're going to talk about in a moment, found opioids not superior to non-opioids for improving musculoskeletal pain-related function over 12 months. It was published in January of 2018. It's referred to as the SPACE trial. Get ready, it's coming up in the next few slides. There were some limitations to that study. We'll mention them right away, and then we'll come back to them. The study did exclude patients already on long-term opioids, and that was a lot. And also 89% of eligible patients were not enrolled. So it may not be fully generalizable, but that doesn't mean it's a bad trial at all. 2 longer-term follow-up studies of people who had been in trials, but then the trial had ended, found that about 44% of people on chronic opioids for chronic pain were still receiving 50% pain relief at a later time. So there's some percentage that just continue with that treatment, usually without dose increase, by the way. Okay, so the headline, aren't opioids no better than Tylenol? I heard that somewhere. So it was a trial published in JAMA, effective opioid versus non-opioid medications on pain-related function in patients with chronic back or hip or knee osteoarthritis pain. This was the SPACE trial. It was for adults. It was 248 veterans. They were people who volunteered to be randomized, which might not be the same as every patient we see. As I mentioned before, the numbers of people identified for possible entry to the trial were over 4,000. Most declined to be in it or they weren't eligible, so we're left with 248. It is a one-year trial, however, and that makes it very unique. Both interventions involved medicines that were on the VA formulary. Each arm included 3 steps of medication. The arm that's traditionally referred to as the non-opioid arm probably was best called the non-opioid first arm, as you're going to see. The other arm, which is referred to the opioid arm, I might refer to as the aggressive opioid arm. So the non-opioid arm provided acetaminophen and naproxen as step 1. If people didn't do well with that, they got some combination of nortriptyline, capsaicin topical, and gabapentin. And step 3, for a very small number of that trial arm, was a weak opioid, tramadol. On the other side, the opioid arm, or the aggressive opioid arm, involved morphine instant relief or hydrocodone in step 1, adding a sustained action opioid in step 2, and in step 3, transdermal fentanyl, which seems pretty aggressive for osteoarthritis pain. So that's why it's a little different from the way it was advertised. How'd they do in terms of pain? This is from the brief pain inventory, and basically there's 2 lines on this slide, and they're almost the same color, and they have the same path. Everybody went from an average pain, on average, of 5.5 down to 3 or so. So nice improvement over a year, no difference between the trial arms. Pain scores, which is a little bit different from pain-related function, they look about the same, but by the end there's a hint of a difference. And that red line with a slightly higher pain score, p-value 0.03, is actually the intensive opioid arm. And that orange line with a slightly lower pain score is actually the one where opioids were held in reserve and only offered to a small number. Depression scores. There's been a concern that opioids simply cause depression. This trial essentially tested that proposition, and at least in these people, there's absolutely no hint that anybody was developing depression as a result of receiving medications in either trial arm. Here's my take on the SPACE trial. Opioids were not proven to be ineffective. However, intensive opioids were not better than a systematic step-up of therapies in which very low-dose opioids were reserved for a few held in reserve. Opioids didn't seem to cause depression. I still think they might, but they clearly did not in this trial. Both groups tended to improve a lot, which was interesting to me. The SPACE trial doesn't necessarily capture all the people I take care of in my own clinic, where I work with very vulnerable individuals. The pain scores on average at the beginning were 5 out of 10. I tend to take care of a lot of people who say they have 7, 8, 9, and 10 out of 10. It may still generalize to them, but I'm not sure. Improvements were seen for 60% of the patients. That's a much better rate of improvement in this trial compared to most other pain trials, suggesting a potentially good prognostic group. And then finally, I guess I would say this. If aggressive opioids for patients like these, people with standard run-of-the-mill osteoarthritis, was your previous practice approach, now's the time to let it go. This trial suggests that that is not better than essentially a stepped-up approach with weak opioids in reserve. So who might need opioid therapy? Opioids are not first-line or routine for chronic pain. You could invoke exceptions on ethical grounds or practical grounds. Somehow the patient can't get any other form of treatment, can't tolerate any other form of treatment. They have multiple illnesses. Any number of reasons you can invoke an exception, but they're not routine or first-line. Some pain-related distress can be mitigated with mitigations, including opioids, but you do have to anticipate the risks if you're going to start them. Generally, it's appropriate to combine opioids with other therapies to address the pain issues. How often do adults who get opioids, start opioids, develop new addiction-like behaviors? And we're going to spend a lot of time now on addiction, but this is actually a prospective follow-up study of mostly middle-aged adults from University of Pennsylvania clinics who were started on opioids for chronic non-cancer pain, and they just followed them closely. Age 47, there were 180 people. This was published in Pain Medicine in 2018. They excluded people who had obviously active drug, alcohol, or psychiatric problems in the preceding 3 months. The mean dose patients reached was 19 morphine milligram equivalents. There probably were a lot of people who were getting 5 milligrams of hydrocodone twice a day, which is 10 morphine milligram equivalents. Maybe they were getting 7.5 4 times a day, but this was not a high dose trial. 28% simply stopped the opioids. Either the problem must have gone away or they just didn't like them, and that's very common in trials. Among their urine drug test results, you see that cannabis was found in 8% at baseline and 9.7% at 12 months. They weren't changing therapy based on the cannabis, basically, but it is a thing that you're going to see if you're testing urine, which you probably have to do given the current environment. Prescribed opioids were not detected in the urine about 16% of the time. They didn't assess why that was, but they didn't have strong reason to believe that there was diversion going on. Finally, the group mean pain score didn't fall significantly. So if you go with this treatment, you can't assume that the individual is going to come back later and say I had a massive improvement. Although the truth was in the SPACE trial, both trial arms had a great improvement. So what would be addiction? Here we need to use the current terminology that's used in the DSM-5, which is opioid use disorder. This has replaced terms like opioid dependence, which used to be a diagnosis, and opioid abuse. To anticipate the diagnosis of opioid use disorder, I've grouped the criteria into three clumps with those red brackets. The top ones, taken more than intended and unsuccessful cutting down, involve taking too much. Then there's four sets. Craving. Craving sits on its own as one thing you need to remember. Then any hint of life problems due to recurrent use of the drug, those are key to the opioid use disorder diagnosis. And there's a bunch of different ways of listing it, which I'm not going to read out loud. And then finally, withdrawal intolerance, which are indicators of physiologic dependence on opioids, can be used in the diagnosis of opioid use disorder, but there's an exception clause, which is if the only evidence of withdrawal intolerance is because the person is on medically prescribed therapy for pain, it can't be used in the diagnosis of opioid use disorder. So in those people, you're going to have to look for evidence if you're trying to diagnose that, life problems, craving, and taking too much. So how many people actually develop addiction? We often hear it said that everybody can develop addiction. No one is immune, and that's true. If you look across American families, almost all of us have someone either in our current close family or remote family who has some kind of addiction. But in terms of the percentage of people who develop addiction to opioids de novo without having prior addiction and or starting opioids for chronic pain, the estimates we have range from under 1% to 6.5%. Those are typical estimates from large studies, including the estimates that are cited by the National Institute on Drug Abuse. Another important point to make, and I'm showing a photograph of a colleague and collaborator, Dr. Sally Sattel here, is that we're not all equally liable to addiction. This is what comes out of addiction research and literature is there are characteristics that make people quite a bit more liable to develop a new onset addiction and characteristics that do make them less liable. No one's immune, but we vary and we differ. Probably the easiest way to look for an example of that idea that people's liability is different is to look at the opioid misuse and poisoning rates among people who've received opioids after surgery. And that was actually done in a study that was published in British Medical Journal in 2018, looking at a large commercial database where they looked at people who had not been receiving opioids, had no prior addiction, but then got opioids for some length of time after surgery. The main finding of the study was that there was an association between the duration of that prescription and the individual's likelihood of having opioid poisoning or overdose or addiction or some kind of other event later in the record. But there was another finding that's pretty important, and it was in the appendix to the study. There was a very, very, very high risk for individuals who are aged 15 to 25, 500% increased odds of developing new problems for that younger age group. What does that mean? Well, if you have a 21-year-old who has surgery and you're taking care of them and you're the parent perhaps, you probably should not let them handle their own pills, but handle it for them, particularly if they've been messing around with any other substance previously. We change in terms of our proclivity to develop a new addiction depending on our age, depending on our past trauma history, depending on our childhood experiences, depending on prior addictions. All of these things are involved. Can I treat opioid use disorder? So, I'm speaking to a presumably mixed group of doctors, but it probably includes many internists, general primary care people, family medicine doctors, probably some non-physician providers, including nurse practitioners. So there are medications that can be used to treat opioid use disorder. There are 3 that are approved and have evidence in the United States. Methadone, when it's being used to treat addiction and a diagnosed opioid use disorder, you can only prescribe that through federally licensed clinics for that. You can prescribe methadone for pain if that's what you want to do, but not for addiction without working out of a specific licensed clinic. Long-acting naltrexone, The person does have to get off all other opioids for 7 days, and that means potentially going through withdrawal. There is evidence that it's effective if people take that treatment and adhere to it, although it's sometimes very hard for people, particularly heroin users or people with very severe addiction, to get through that 7-day period to even start the medicine. Finally, there's a combination product. Buprenorphine, which is an opioid, it's a partial agonist, and naloxone, which is an opioid counteracting agent. And the person needs to get off of opioids, and I wrote here 12 to 36 hours, but probably even 8 to 12 hours is enough. They need to be in very mild or moderate withdrawal to start buprenorphine naloxone, and it occupies the mu receptors in the brain, which are the opioid receptors, and it partially stimulates them and alleviates withdrawal. All of those have evidence. In saying this, I do have a note on the slide, which is that much of what happens in addiction recovery does unfold in ways that are separate from what we doctors do in the clinic. So there are other things in people's lives that determine a lot of their decision making around drugs and alcohol. We're not the sole determinant of that. I think we all sort of know that. Legally, how about prescribing these things? Well, if you're in the hospital treating somebody for pneumonia or for a heart attack, and they happen to have opioid addiction, you prescribe any of these medicines. You don't need a special license or a special waiver as long as it's attendant to the care of that medical disorder. To keep them in the hospital, you can, and most of the time, you should if you want to keep that hospitalization stable. To prescribe buprenorphine naloxone combination product for opioid use disorder as an outpatient, you have to do a training. And it's 8 hours max, and it can be done in person or online. Then you get a certificate, you upload it to the website for United States Substance Abuse and Mental Health Services Administration. They then forward it to the Drug Enforcement Agency, and then 45 days later, you get a revised Drug Enforcement Agency certificate that says you can prescribe buprenorphine naloxone to outpatients. There's a website for free training if you'd like to do that. The other thing to know is that you can prescribe various forms of buprenorphine for the care of pain, and then you don't really need the waiver. So there are FDA-approved products that are buprenorphine containing, including a patch. Those are often hard to get paid for by the payers. Buprenorphine naloxone combination tablets are used for treatment of addiction, but they're not quite as expensive, and sometimes that can be used in the care of a pain patient, but that's an off-label use, although it was mentioned in an HHS guidance this autumn. I've talked about pain care. I've talked about opioid use disorder. There's probably a need to discuss the fact that for many of us, we see something that feels like not addiction and not like a really straightforward pain case either. It's something in between. I'm going to share with you some language and some ways of thinking about that are still being debated today, but are a little bit helpful when you're working on the front lines. Dependence. Dependence means that when you're taking something and you stop it, you don't do well with it. In principle, you can be dependent on a beta blocker because stopping it could cause a problem, dependent on another pharmacologic agent. And dependence takes various forms, from entirely benign to really dangerous. Simple dependence, which I have in a pale box with black writing here, is essentially that the person has tolerance to the opioids they're receiving, and that if they were to stop them or reduce doses, they would have some withdrawal, and it would not be protracted, and it wouldn't be destabilizing. That's basically what many of us were taught was what would happen to anybody who took opioids for long-term pain, which turned out not to be true, but it still is the case for a very significant number of patients, simple dependence. Then at the other end of the spectrum is this diagnostic term in the DSM-5, opioid use disorder. And they're doing terribly, and they are craving, and they're wrecking their lives around those pills or whatever it is that they're taking. That is a diagnosis in the DSM-5. In the middle, there's areas of gray. And in these areas of gray, we see trouble. One term has been proposed to describe that area of gray, but it's being debated as to whether it is the right term or whether we should have a term. But I'm going to share it with you. It's called complex persistent dependence. In these situations, the way it's usually described is the individual has both pain and affect that are volatile, and more volatile than you'd hope them to be on a good treatment for pain. Escalating the opioid dose doesn't seem to reduce the problems. And unfortunately, the next step that you think is I'm going to reduce the dose, but that often turns out not to be helpful as well. There's some overlap between this, potentially an opioid use disorder, but all of the problems are attributable to the fact that the person has long-term pain and they're in care and they're on this particular treatment, which is sometimes not a very good treatment. In fact, often not a very good treatment. And whether we're going to embrace this term or not, the key thing is to recognize there's some people who are in this in-between zone. The notion of complex persistent dependence, if you adopt it, reflects the situation of the patient being volatile and not doing well in the treatment. If your entire institution is tapering everybody, and some people do terribly, that's not what the basis for making that diagnosis is. Okay, standards of care. I'm going to talk about the CDC guideline, but most recommendations in it you should understand are based on type 4 evidence. It is a consensus. That's very important because it's a consensus. But type 4 evidence is clinical experience and observations, observational studies with important limitations, or trials with major limitations. Most of the key components of the CDC's guideline are here on this slide. In terms of initiation, we've really talked about not using them as first-line therapy. It's really important to set goals in terms of activity improvement and things a patient will do if they're going to be taking this treatment. How will you know they're doing better? I ask patients to tell me, what are you doing today? If your pain gets better in 3 months, what are the activities that we're going to be discussing 3 months from now that you're doing in the future? In terms of management of opioids, the CDC recommends immediate release opioids over sustained action, particularly when starting. Prescribe the lowest effective dose, and particular caution with escalating the dose and deciding whether to do that. You have to reconsider the risk-benefit profile. Prescribing short durations for acute pain makes sense. It's rare that you need to give someone more than 7 days for an acute injury. And evaluate the benefits and the harms of the treatment that you're providing. They offer a number of items to try to mitigate risk, many of which are now required by law or by payers. Checking the prescription drug monitoring program is required in most states. In Alabama, it's based on the actual dose the patient is receiving. But if they're at under, I want to say this carefully, 30 morphine milligram equivalents, it's according to your clinical judgment. If they're at over 90 morphine milligram equivalents in Alabama, you have to check every time you renew the prescription. Avoid concurrent benzodiazepines to the extent possible. There will be some people where that is a decision you and potentially their psychiatrist reach together, but that's not common. And offer to treat people with opioid use disorder. So what must I do if I'm prescribing? What you must do combines obligations to the safety of the patient and obligations that are derived from regulation, which I've begun to touch on. I tend to mention both these things to patients. I'll say, there are things that we need to do that will help to assure that you're safe and benefiting from this treatment. And by the way, it's important to know that society considers these prescriptions sensitive. This means that for me to prescribe them, we have mutual obligations that we have to uphold. And that's, why do I do that? It's just to be honest and clear with the patient. We're dealing with two things at once, what's good for them and what I have to do given the rules that are upon us, and me as a physician, and I want to keep my license. This sets the stage for later discussion. If the patient's behavior changes in a way that doesn't seem like you can regulate or manage it, then you can say, remember what I said at the beginning. When initiating opioids, goals for pain and function, like the CDC said. I would refer to a model that's based on a gain in activity or rehabilitative function gain. If the person's been completely bedbound for 2 years, maybe that gain in activity is getting out the front door for 10 minutes a day, and that's a step that they need to take. But that's not so often the case. The other question is to ask if there are other professionals needed. This would apply whether you're starting opioids or not. Do we need rehabilitation? Do we need mental health care? Informed consent. This is not a contract. Actually, it's more like a conversation about the responsibilities we've taken on and the fact that there is a risk to this treatment. Addiction, overdose, potentially other things. One can frame this as a trial of the therapy with an option to stop it if there doesn't seem to be any progress based on offering it for a period of time. Finally, clinicians should continue therapy only if there's clinically meaningful improvement in pain and in functioning from that therapy. Some of the things I ask when I'm taking care of patients in pain care, regardless of whether they're on pills, but certainly if they're on them, what are you doing each day? Are you working? Are you taking care of other people? Sometimes people aren't working because they are the sole caretaker for somebody else who's disabled in the household, but that's work too. Are there groups that are part of your week? A social life is often an indication of relatively better functioning. Do you walk? Do you play an instrument? All these things are things that people do that you can document in the chart to show that you assessed how the person was doing on this therapy, whether they were doing well or poorly. I mentioned the prescription drug monitoring program requirements. I'm not going to restate them, but there's a slide that kind of reviews how often you have to check depending on dose. I should caution we don't have evidence that any patient-level outcome is actually improved by checking the prescription drug monitoring programs, but analyses do suggest that prescriptions tend to fall when laws are passed requiring you to check them. Urine drug tests. In the Veterans Administration, I'm asked to check every 6 months, so that's what I do. A standard screen to use is an immunoassay, which is less expensive and is somewhat less sensitive. There's still false positives you need to know about with immunoassay tests, especially the amphetamines. Many of the drugs that we prescribe therapeutically will ring false positive, especially on the amphetamine screen. There's a website, mytopcare.org, which has a nice urine drug test interpretation tool. You can click over to it, but particularly just caution, there are some false positives. Low-dose hydrocodone leads to the situation of negative urine sometimes. It's worth asking patients, if you're prescribing 45 tablets a month to a patient, and they take 1 a day sometimes, 2 a day sometimes, and then they're out sometimes, or they just don't take them for a week because they forgot they had the pills, which really happens, their urine drug test will not show the drug that they take. So the response to both positives and negatives is a conversation to ask about how they're using the medicine, and often a confirmatory test. If you want to do a more sophisticated confirmatory test, the GCMS would be appropriate if you have a concern. The other thing to recognize with urine tests is they are tests, they're not oracles. They do not tell you everything you need to know about the human being that you're taking care of. They can be subject to flaws, specimens can get swapped, lost, patients can cheat, all those things can happen. We don't really have much improvement that checking these tests actually improves patient outcomes. I still sort of check them and discuss them with the patients. What about opioid reduction? Here we have to acknowledge that a lot of patients are being reduced in response to policy pressures. I'm showing an example here of a letter from a medical practice to a patient. The letter says that the Centers for Medicare and Medicaid Services has implemented a new law, which is referred to as HB 21, with a maximum 90 morphine milligram dose requirement. The letter itself is a miscitation since HB 21 is a House bill in the state of Florida. CMS doesn't implement laws directly like that. And that's kind of common because we're in a bit of a panicked era around these prescriptions. The physician's offices are going to taper by 10% a week. That is probably not safe for most patients. And then it says that most patients have less pain when they're on lower doses. That is not entirely proven unless the patient is working with experts and has consented for the taper. So this is kind of the environment we're in. The reason it feels a little chaotic for a lot of us clinicians right now is that there's so many voices all simultaneously reshaping opioid policy. So I've put a series of 4 boxes here that lay out the governmental voices, the guidances and the metricses, and the payers and other health entities, pharmacy chains, insurance companies, state regulators, federal regulators, multiple regulators, the Congress. And then since most of us really don't have the time to read all the documents these regulators are producing, a lot of us respond to what I call framing voices, which you see in the upper right-hand side, which is whatever a journalist writes or the cover of a book or an advocate. And we say, I guess this is kind of messy and I don't want to be involved in this. I'm trying to make it seem like you can sort of assimilate this information into grand rounds, but that's why it feels so crazy. Well, what do we know? A lot of people are being reduced. What do we know about the outcomes of that? There was a paper published in Annals of Internal Medicine in 2017 that reviewed all the available trial data on patient dose reduction and stoppage. There were 40 studies that had any kind of patient outcome. Only 5 were randomized controlled trials. Most of the rest were observational studies. None of the studies were rated as even good quality. So we are in a very low evidence zone right now. Improvements were found in a couple of those fair quality trials. Pain in 8 out of 8, and pain-related function in 5 out of 5. The stipulation is these were all people who volunteered to be in the trials. These trials typically entailed a weekly follow-up and multidisciplinary support, so it's not just cutting doses every 2 weeks or every month or every week and hoping things go well. There's a lot of service involved. They tended to have short-term follow-up, which kind of resembles the original data we had for opioids. There's no real studies of mandated opioid reduction. So when somebody says the law is making me do this and I'm sure you're going to feel better, that's never really been studied. There's insufficient evidence really, or at least this is in 2017, they said there's insufficient evidence on what adverse events might result. Those were cautionary statements, and I've summarized them here, but basically in that review they said, we don't know what happens when you make everybody take everybody off these medicines. One of the things that does happen and has gotten my concern and is mostly anecdotal at this point is suicide. So this is a story that was reported in the news in Utah, ABC4, a family out of Pleasant Grove. And the father in the family is Adam Palmer. And the ABC News reported that due to insurance and dosage changes, Adam no longer had regular access to the pain medication he needed. He was a working guy, he'd been on pain meds for a long time, and the whole thing just kind of fell apart because of insurance changes. Unfortunately, Adam decided that his only way out of the situation involved killing himself. And there's a quote from his daughter who says, "The night before he left, he gave us all hugs and told us how much he loved us. I'm glad he's not in pain anymore, even though we do miss him." Well, that is the kind of thing that's affected our community too. I'm very aware of cases in Alabama and in other states where we're seeing this happen. The numbers are not entirely clear. But research has come out in 2019 suggesting that not all opioid reduction is followed by a patient who seems to be doing well or is safe. Dose variation was associated with an increased risk of overdose in a Kaiser, Colorado database, although those people who got all the way to zero, not sure why, but who did, had lower risk of overdose. Stopping opioids was associated with suicidal ideation or an action in that direction in 11.4% of a small study looking at veterans who were reduced in 2011 and 12. The cessation of patients who had been on high-dose opioids in Vermont, this is a Medicaid review, it was typically rapid. About 50% were cut off in one day, and was often followed by a need for emergency medical care, which doesn't sound good. Opioid cessation was associated with 3 times increased risk of overdose death, although this was a small study from Washington State controlling just for sex, age, and race, but still a concerning finding. These overdoses probably are not due to the prescription opioid, but to whatever the patient went on to use after the opioids were stopped. It doesn't necessarily mean cause and effect, but it's a concern. Cessation of opioids in a New York study was associated with termination of outpatient care relationships. These are all observational data. None of these actually prove that the opioid stoppage caused the outcome that I've just described. But they're not reassuring. They do show a discrepancy between what seems to happen typically when opioid pain medicines are stopped or reduced and what might be the ideal, which would be more like the trials reported in the Frank study. It's a big discrepancy from improvement on the one hand to lack of safety on the other. So the last year has seen a recognition that there is something that's not quite going right with these opioid stoppages and reductions. There was a consensus paper which I served along with Kirk Kroenke and other pain and addiction experts saying there were some challenges with implementing the CDC guideline published in January. The United States Food and Drug Administration in April put in an announcement saying that they had defined harm from sudden discontinuation of opioids and opioid pain medicines requiring a label change, and they noted specifically a risk of suicide after stoppage. The Centers for Disease Control and Prevention issued a similar kind of recommendation. I actually had led a letter to the CDC. It may well be that our letter had some role in issuing that clarification, but they said, we meant for our guideline to be used cautiously, and a lot of what's being done right now doesn't look cautious to us. We need to be careful here. And finally, in the autumn of 2019, the United States Department of Health and Human Services issued a guide for clinicians on appropriate dosage reduction or discontinuation of long-term opioid analgesics. What they said in that guidance was to avoid misinterpreting the cautionary doses like 90 or 60 or 30, whatever it is, as a mandate to take every patient down below that dose. They did say to consider tapering the patient if pain improves, or if the patient asks for that, or their pain and function are not meaningfully improved, if there's a higher dose that the patient's receiving but it's not apparently benefiting them, and if there's overdose toxicity or current misuse. But they emphasize going slowly. And they also said tapering should be part of a comprehensive treatment plan, which had a long definition, but relates more like those trials that I described earlier. They stated that there are serious risks to non-collaborative tapering, acute withdrawal, pain exacerbation, anxiety, depression, suicidal ideation, and self-harm, ruptured trust, and patients seeking opioids from high-risk sources, so beware. Taper is successful if the probable risk improvement that the patient obtains can be balanced with a degree of achievement in their goals that are important to them. If there's stability or improvement in pain and function, if it avoids instability and harm related to medical, psychiatric, and psychological conditions, if the patient feels that they're treated with dignity and respect, And if the patient's involved in that decision-making process and remains engaged in care, that doesn't mean that they are the controller of your prescription pad, but that they're involved in that conversation. So the summary of this talk, as we reach 50 minutes, context. Our crisis includes and is partly due to a proliferation of prescriptions that are now in decline and have been so since 2012. What we have done to correct course in the opioid crisis has drawn some concern from the Food and Drug Administration, the Centers for Disease Control and Prevention, the U.S. Department of Health and Human Services, patients, and the media as of 2019. Essentially a pendulum swing. The model. If we want to care for people with pain, we have to ask fundamental questions about the pain experience itself. We have to interpret all the factors that create the pain experience. Instead of thinking of pain as just a thing that happens to your hand or your head, think of it as a thing in which your body and your brain incorporate a message that decides, I'm in trouble or I'm not in trouble. Evidence. Opioids are not routine first-line therapies. Dependence. It can take multiple forms. There is a form of dependence which is relatively benign. We were all taught, probably incorrectly it seems like, that all patients on long-term pain opioids are going to be in this benign form. There's a form of dependence that is really addiction, and there's a gray zone in between. Standards. Standards of practice include caution, documenting the discussions that we've had with our patients, assessing the risk and benefit of the decision to start a treatment and to continue it, and tapering. There are plausibly ideal ways to taper opioids if that's the decision that is reached. It's not simply mandated based on a dose that the patient is receiving, according to the recent guidance issued by HHS. There is currently a difference between what's typically happening for patients in today's policy environment and what would be ideal. And with that, I'm done, and thank you very much for your attention to this talk.